Physiology and the clinical aspects of the drug. Also talk a little bit about a couple studies that are out in the literature in pediatrics regarding dexmedetomidine, and then discuss some practical issues related to its use, and hopefully answer some of your questions if we have time from what you see at your end when these patients hit the recovery room. So Dex has been used for a variety of indications, and it's because it has such a diverse profile clinically. It can cause sedation, anxiolysis, analgesia, sympatholysis. It has a very stable cardiac profile. It maintains respirations, and it decreases our need for other general anesthetic agents. So it has a lot of good uses for us and also for you, as I hope I can show you. It's been around for about 20 years, was FDA approved in 1999 for the use of for sedation in the ICU in intubated mechanically ventilated patients for less than 24 hours. That's what they call a short-term sedation. And you know, in spite of the fact that there's a real need for good sedatives, there really hasn't been a whole lot of work on new agents other than Dex in the last 10 years. And you see some of the issues that we have with our current agents. The ones we probably use the most are opiates, benzodiazepines, and propofol. Propofol, we're getting issues with access throughout the hospital. It does not have any analgesic effects, and it has its own cardiac and respiratory problems. Benzodiazepines, again, also no analgesia, and there's some tolerance issues that occur with chronic use or with IV drip use. Opiates, the big issue that we see in the recovery room is that we all worry about the most is respiratory depression. So how does Dex work? It works through alpha receptor agonism, so it's an alpha-2 receptor agonist. So a little background on alpha receptor agonist. The prototype is clonidine. It's been around since the 70s, and we've used it in our practice for sedation. We also see it in our patients for treatment of ADHD, and it's a very commonly used antihypertensive. Problem with clonidine is that it's orally absorbed, so it's slowly absorbed. It has a very long half-life, about 8 to 12 hours, and it has some real issues with hypotension. So we're looking for, as a solution to these problems, an agent that's more alpha-2 receptor specific, and I'll talk about why that's important in a few minutes. So dexmedetomidine is called Precedex. We use Dex as its nickname. It's a pharmacologically active D-isomer of medetomidine, I'm sorry. And the important part is it has an 8-fold increase in alpha-2 receptor selectivity, and that's going to be important when we talk about analgesia, amnesia, sedation, and anxiolysis. It has a much shorter half-life than clonidine, 2 to 3 hours versus 8 to 12 hours, so that it's much more easily titratable than clonidine. It's been FDA approved for use in ICU in adults, and pediatric trials are in progress, but we are using this drug, like most of the drugs we use in anesthesia, off-label for pediatrics. So a little bit about the pharmacology of this drug. It onsets in about 5 to 10 minutes after a bolus dose, and it starts to peak at 15 to 30 minutes, and its duration of action is about an hour to 2 hours. So that's important for you folks, because when we're giving this drug in short cases, or we give it towards the end of the case, it's actually, you know, like for example, a tonsil. After induction, IVs put in, we give the medication, and we're in the recovery room in 20 or 25 minutes. You will be seeing the peak effects of this drug. You're the folks that are dealing with the peak effects, not us. So that's why you may be seeing some of its side effects and some of the less positive effects of this drug in the recovery room. It's almost entirely metabolized by the liver through the cytochrome P450 isoenzyme family. So anything that affects that isoenzyme group, and the one that we see, the family we see most often that affects cytochrome P450 is the anti-epileptics. So anything that affects that enzyme group is going to affect this drug's metabolism. So in general, patients who have, for example, the anti-epileptics on board may have an increased metabolism of the drug. It's eliminated in about 2 hours. Depends on if it's bolus or drip. It's about 2 hours for bolus, maybe 2.5 hours in peds for prolonged IV drips. But somewhere in that vicinity. It's excreted 95% in the urine, 4% in the feces, and there's no metabolism in the urine, so it's safe to use in patients who have renal insufficiency or renal failure. It definitely has to have its dosage needs to be cut back in patients who have liver insufficiency or hepatic failure, because it's almost entirely liver metabolized. So half-life in liver failure goes from 2 to 8 hours. So something to keep in mind in those patients. How does it work? Well, its CNS effects are mainly in 2 areas, in the brainstem and in the spinal cord. And in the brainstem, it affects the locus coeruleus, which is the area that's associated with wakefulness. So those alpha-2 agonist receptors will cause, when that drug locks onto those receptors, it's going to cause a reduction in wakefulness, so some sedation and some anxiolysis in that area. In the spinal cord, alpha-2 agonism in that area will cause ultimately reduction in the release of substance P, so you're going to get analgesia. So that's where it has its analgesic effects. And those are the 2 main areas in the CNS. So here's a schematic of what I just said. If you look on the right, you see the dexmedetomidine affects the locus coeruleus, which is that part right here near the floor of the 4th ventricle, and alpha-2 agonism in that site causes sedation and anxiolysis, and then in the spinal cord it causes analgesia through decreased release of substance P. At the nerve level, what happens, those little blue triangles are the dex itself. That medication will latch onto the alpha-2 presynaptic receptor, and that causes a negative feedback loop. So the more agent that's attached to the alpha-2 receptors presynaptically will cause a decreased release of norepinephrine. So the more drug that you have there, the more that negative feedback loop takes place, and the less norepinephrine is released into the synapse. And that has important implications for cardiac issues as well. So what are the cardiac effects of dexmedetomidine? Well, it's largely blood pressure related and heart rate related. And the primary heart rate effect is bradycardia, and it does it mainly by inhibiting cardioaccelerator fibers, so that the nerves that actually increase heart rate are blocked, so that the patient's going to have some bradycardia from that effect. And also it has a direct vagomimetic effect, so it actually has vagal properties and will decrease heart rate that way as well. So you can get some pretty significant bradycardia. I don't know if any of you have actually encountered that in the recovery room.
I was going to ask you if you've seen it at all, because I don't think I have, but
it's more related to when you bolus the drug, and if you bolus it rapidly and you give a large dose. So we've learned that if we bolus it over the course of 10 minutes, and we're often using a smaller bolus dose than what we all started off with, you're not going to see that bradycardia, and you probably don't see it as much in the recovery room because it's starting to offset by the time you get here. What you might see is the blood pressure changes. And the first, it's a biphasic blood pressure response with this drug. The first thing you're going to see is some hypertension, because although this drug is an alpha-2 selective drug, it does have some alpha-1 effects, and we know that alpha-1 agonism causes vasoconstriction of blood vessels. And for those of you who worked in the ICU, the prototype alpha-1 agonist is Lefebvre, and we use that for blood pressure control by increasing vasoconstriction, increasing afterload, and increasing blood pressure. So this drug has a little bit of that effect, but it's dissipated very quickly. And the much more common effect that you see blood pressure-wise with dexmedetomidine is hypotension, and that's because, again, when this drug hits the vasomotor center in the brainstem, which is the center associated with blood pressure control, you're going to have decreased release of norepinephrine, like we just saw in that schematic, and you're going to have a reduction in sympathetic outflow and a decrease in blood pressure, and potentially some hypotension. Its respiratory effects this drug is promoted as having minimal ventilatory effects, so it's been a big reason why it's become so popular. It has minimal effects on respiratory rate, PaO2, SATs, and PCO2, even in large doses. There's been a lot of work looking at this because it's been used not only in the ICU in patients who are intubated or who are trying to wean from the ventilator, as a sedative, but also in spontaneously ventilating patients for procedures under sedation. So lots of information, especially with adults, and I think that's one of the reasons why you're seeing this used more and more. Endocrine effects, well, we know that Dex stimulates the alpha-2A receptors, and that works to decrease the release of catecholamines and then decrease the stress response to surgery. So it's great because stress hormone release in surgery is bad, and it causes a lot of bad things. It causes not only just the acute blood pressure surges that we see in the OR, but also problems with the immune response, with healing, and so forth, in the recovery room and on the floor ultimately. This drug also promotes a natriuresis and a diuresis, which is different than most of our general anesthetics. You folks know that a lot of times we'll have a totally unremarkable anesthetic and yet the kid won't pee, because all of our agents affect the renal system in that way. And this is one of the few drugs that we use that actually maintains urine output. They don't know why. They think there might be some reduction in output of the renin-angiotensin system, but for whatever reason it does promote a diuresis, and that's being carefully studied right now. Its structure is similar to etomidate, which is one of our induction agents, but it doesn't have the inhibitory effects on steroidogenesis that etomidate does, so you don't need to give exogenous steroids. So here's a comparison of Dex with other sedating agents, and I hope that this slide actually shows you why it's become so popular. Because if you look at the commonly used sedation agents that we use, and we don't use Haldol, but the benzos and propofol and opioids, in addition to the sedation that all these agents produce, Dex has some other really good properties, and I'm going to just tap you. So the first one, just quick, if I was a recovery room nurse, I'd want my patient not only to be sedated, but I'd also want them to be pain-free. Next, I'd want a patient who is not only sedated and pain-free, but not anxious, because we have patients that are, you see that have sedation, they're pain-free, but they still have extreme anxiety in there, and that's different than emergence delirium. You don't want them to be respiratory depressed. It's a big issue in the recovery room. And then finally, if you had to, you don't want them to have emergence delirium, big problem in children, but also in adults in the ICU. Not so much in the post-op, but you will see it a lot in the ICU, it's ICU psychosis for those of you who've done time in the ICU. And then finally, as a recovery room nurse, you'd also not want them to shiver. So the drug actually has fulfills a lot of the properties that we look for in a good anesthetic agent from your standpoint in the recovery room. But we know that it's not perfect. There's also adverse effects to dexmedetomidine, and the first one that we talked about is hypertension, which, as I said, is probably not something has anyone seen that in the recovery room? Okay, so most of the time, there's enough time that acute bolus effect has dissipated by the time we get to you. How about hypotension? Okay, so people have seen that in the recovery room. And bradycardia? So those are the three main adverse effects that you might possibly see in the recovery room. And, hypotension can be pretty profound, and because, again, sometimes it's hard to figure out whether or not it's this drug versus the propofol, or this drug versus the SIVO, or the patient who's intravascularly depleted to begin with. But luckily, this responds to fluids, and it also responds to ephedrine, which is a commonly used agent for this problem. Bradycardia is also can sometimes, anyone see bradycardia? Okay, and sometimes it can be pretty profound. Again, it's self-limited, so if it's not associated with hypertension, it will go away by itself. It does not need treatment. There's reports, kids get down to 30s and 40s, and everyone gets pretty worked up then, but if they're maintaining their blood pressure, they're maintaining, then it does not need to be treated. If it does need to be treated, it does respond to both robenol and atropine. Then one more. And I just include this, these other things are very uncommon. It's just almost like the PDR version of adverse effects with Dex. But with long-term use, a lot of patients come down on Dex drips, or may have had Dex drips in the ICU. If they inadvertently get turned off, or they've been weaned recently, I just put that up there because if you have a patient who's hypertensive and anxious and jittery in the recovery room, it may be that they're withdrawing from the drug, and obviously the treatment is to start them back up on their drip. So how do we dose this drug? In the ICU, there's no real reason to load the patient. So you start off at about 0.7 mics per kilo per hour, and then adjust it up or down according to the clinical response to either in a range of 0.2 to 1.4 mics per kilo per hour. In the OR, we usually give a load of 0.5 to 1 mics per kilo, and then we start off with a drip of about 0.6, and it's a little bit narrower range than in the ICU, anywhere from 0.2 to 1 mic per kilo per hour. It can be used as a pre-med, so that if you do want to use this in the preoperative area, you can use it intranasally, sublingually. Orally doesn't seem to have as good bioavailability, so those are the two routes that we typically use with Dex. And if you use a 1 mic per kilo, for example, in the intranasal dose, that corresponds to about 0.5 milligram per kilo of Versed. So it's about, that's about the equipotent dose. It's also been used in very selected cases as a single agent anesthetic. For example, when we have patients who have tracheal stenosis or are having airway procedures where we need to keep them breathing spontaneously, but we can't put a tube in, so we can't deliver gases, and all of our other IV agents, reduce respirations. This drug is very good to maintain not only ventilation but airway patency, and so they recommend 5 to 10 mics per kilo per hour, which is about 5 to 10 times our normal IV dose. It sounds like a lot, but with these particular cases, if that's used, they've reported that, and I have not used it at that high dose for any cases, but they've reported that the patient continues to breathe spontaneously and maintains their airway. So very unusual. All right, so what are some of our perioperative observations with this drug? The hypotension that we see when it's in the OR is really no different, and actually maybe less than propofol, but because of its longer half-life, you're going to see more likely to see hypotension with this drug than you will with propofol, because it extends into the recovery room. We don't use controlled hypotension that much anymore for procedures. That's for when we used to use it for fusions and for Lefebvre's. We still use it for Lefebvre's, where we bring the MAP down a bit with pharmacologically. And when we do that, typically the drugs that bring the MAP down will cause a reflex tachycardia, because this drug has those bradycardic effects. It's good for controlled hypotension. There's a lot of studies that show that this drug that Dex will reduce PACU narcotic requirements. I don't know if you've found that to be the case or not, but it's not throughout the literature. Some studies have shown that in effect, some haven't. There is a blunted catecholamine response, which is helpful when you're using this for vascular cases, really probably more important in adult anesthesia, things like thoracic aneurysm, that sort of thing. And its respiratory effects are minimal. So what are the indications for Dex? Well, as I said, it started off as being indicated for the ICU patient who's intubated, mechanically ventilated as a sedative for less than 24 hours. We're using it longer than that now. It's also been expanded to in the adult arena for sedation of non-intubated patients for procedures. And for pediatric patients, there are none because it's still being used off-label. So I thought I'd talk quickly about clinical applications of Dex, because in talking with some of you, I think that's where maybe some of the concerns or questions are, like why do we use it for some cases and why not others? Why do some attendings use it and some don't? Why do some use it for one type of case, one type of tonsil but not the other? And the answer is that we're still kind of getting our feel of this drug. And so you all have to have some patience with us as we try to figure out what it's really best for. So I'm going to go over some of the applications. The first is premedication, and it's a very good premedicant because it causes anxiolysis, it causes sedation, it helps with analgesia, sympatholysis. So I'm thinking that it may be a good drug for our frequent flyers who come down, who have anxiety up to here. Midazolam doesn't touch them. They're having some pain as well. They're just over the whole perioperative situation completely, and this might be a good drug to use for them. But it has been used in just the routine population. We'll be going over a study with those results soon. Intraoperatively, for all the reasons that I said, it's a great drug. It blunts the response to intubation and extubation. It allows us to reduce our other general anesthetics, so it reduces general anesthetic needs. And so it's something that we're using in the OR for a variety of different cases. It's been used in local regional analgesia. They've included in epidurals, spinals, caudals, and what it does is it improves the quality and the duration of action of the drugs in those particular blocks. It's also used for peripheral blocks, and it expands the duration of action and improves the quality of the peripheral nerve block as well. Sedation in the ICU has been used, and studied extensively in the ICU, and it's unique in that it causes what they call cooperative sedation, and that's a patient who's calm, able to communicate their needs with or without intubation. So it's a real advantage for patients who are having agitation with intubation and mechanical ventilation, especially as they start to wean them from the ventilator. Procedural sedation, this is another area where you may start to see us using it more, because in the adult arena it's used all the time in GI for colonoscopies, EGDs, it's used in MRI, it's used for lithotripsy, endarterectomies, fiber optic intubations. I mean, anywhere where there's a sedation, they're using this in adults, and that's why you may start to see that more for us as well. Because it's a pretty easily titratable drug that onsets quickly and has, and has the ability to be IV dripped. Control of hypotension we've just talked about. Analgesia, it's not only used for post-op pain, but it's been studied for neuropathic pain or chronic pain with good results. Cardiac surgery, it's good for patients who are cardiovascularly stable. I wouldn't obviously use this in a patient who's hypotensive or has any sick sinus syndrome or first or second degree blocks. In neurosurgery, it's found a lot of use because it doesn't interfere with our neuromonitoring. It can be used for awake procedures. It can be used as wake-up tests at the end. A patient's intubated, has a neural procedure, the surgeon wants them to move their arms and legs, but they're still intubated, so it's a good drug for that because, again, patients can be calm and still respond to commands. And there's also some evidence that it might have some neuroprotective effect in terms of ischemia and hypoxemia. It's been used in the morbidly obese patient. I had one myself where it's very helpful because it maintains ventilation, unlike our narcotics. I had a patient in an IR for a stent placement who I gave a 1/2 per kilo bolus of Dex and 25 mics of fentanyl. She was, I think, 120 kilos, and that's all it took. And she didn't need to be intubated. So that's a huge improvement over what we would have to do if we had to put her to sleep. Obstetrics it's useful in patients who are not able to have an epidural, like let's say a coagulopathic patient, and as an alternative to opioids because it doesn't cross the placenta easily, it's so lipophilic, and it doesn't interfere with uterine contractions. Pediatrics we've just talked about, and then there's a whole plethora of other uses of dexmedetomidine. So this is a study that looked at Dex versus either placebo or narcotics in the operating room in terms of need for narcotics postoperatively. And so they looked at 250 studies. They only found 11 that they were randomized and controlled, and there were 434 children who got dexmedetomidine as a bolus, usually within 10 minutes of induction. 440 who got control. 8 of the 11 studies were placebo, so they either got Dex or placebo. 3 of the studies were Dex or opioids. Entropin is either fentanyl or morphine. And these were routine pediatric procedures. The vast majority were tonsils and adenoids, so painful procedures. And what they found is that there was a reduced need for opioids in the recovery room if Dex had been given as compared to either placebo or narcotics. And there was one study that was a very small study that looked at children with obstructive sleep apnea that showed decreased incidence of emergence, decreased need for narcotics, and lower incidence of DSAT. So this may be an area where you'll be seeing patients having this drug on board. The second study that I wanted to look at was just Dex versus midazolam as a premedicant, and long story short, there were 13 studies that were looked at. And what they found is that they either did intranasal or sublingual Dex versus 1/2 per kilo of midazolam, and they found that there was better separation of the patients from their parents, less emergence agitation, and less rescue drugs rescue opioids in the recovery room with Dex versus midazolam, so that it may be a pre-medic that we're seeing more often. So here's your PASU considerations. I hope that you realize this drug is a very good drug for sedation, anxiolysis, sympatholysis, analgesia. It also has been studied for a reduction of shivering and seems to be promising there, and also in its effects against nausea. The potential for bradycardia and hypotension we've already talked about. Over-sedation, have people been encountering that much?
At first.
I think at first that
Yeah.
people were,
But
and
not
I
now.
really think that's linked to the fact that people are using the smaller bolus.
Yeah.
Okay, like
Yeah.
from 1 to 0.5 has made a big difference. But it could be this drug, but it's hard to tell because if you use this drug and narcotics, you reduce its efficacy. I mean, then the whole idea of maintaining ventilation and all that stuff goes out the window. So just keep that in mind, and we're hoping to hear from you folks when you do have something that you notice with this drug to let us know, because that helps us figure out where's the best place to use this drug. And this is a summary. I think it's a great drug for intubated patients. It's a central alpha-2 agonist. It's 95% hepatically metabolized, minimally renally excreted. The dose is about 0.2 to 0.1 or 2 to 1.4 mics per kilo per hour with a bolus of 0.5 to 1 mics per kilo. It can cause bradycardia and hypertension. It does not cause respiratory depression, and it has some sort of analgesic component. So hopefully you have a little bit more understanding of this drug, and you'll be a little more excited about when we use it in the OR. And please let us know when you have an observation about the drug.
When will you start using it intranasally? Because that sounds like something that would help a lot for the kids that have like a quick procedure if the half-life's only, or the peak is like 30 minminutes.
Yes.
And by the time they're out to us, then,
Yeah.
they'd kind of be in that.
Yes, and so I don't think it may not be the right drug for the shorter cases, because it will be onsetting as you guys see it. Now,
Yeah.
it depends on how much, sedation's fine. It's more like the bradycardia and the hypotension that, will keep them here. So I'm not sure we're going to be using that for short cases. I think, like I said, it might be a good drug for our
For intranasally
difficult
before?
Yeah, because I think it may be onsetting if you have an ear tube, it'll be onsetting just as you're getting to recovery room, which is really not what we want. We want it to be kind of past that peak when we get to you folks. Anybody else?
So it lasts for 2 hours, but then when the patient gets to the floor.
Well,
what
the
do you-
half-life is 2 hours, but
okay. So you're
the
still-
duration of action is, it's an hour to 2 hours, depending on if it's bolused or bolused and dripped. And I think a lot of us for the shorter cases are just bolusing it. We're not setting up a drip.
So I guess my question is, have y'all followed any of these patients like a couple hours later on the floor as far as pain?
Yes, well, we have not followed it, but I've talked to some of the surgeons, and that's kind of with this whole cleft palate thing.
Right.
That's where, and I don't know if you folks have had trouble with them or not. It's a bit, does it look like they've been fairly comfortable?
Yeah.
They were good here, but the problem was when we got to the floor, they were so comfortable that the floor was uncomfortable with getting them. I mean, they weren't crying, they weren't bleeding, which was great, but the floor was not prepared to have such a sedated patient. So I think you guys backed off a little bit, so then they're requiring more narcotic or something in here because we backed off, but it's, I think, more so because the floor wasn't prepared for
See, I
having
think to
these
me that's
sedated
more
patients.
of an
Education.
educational opportunity is what I like to describe it as, because I mean it's true, and I've seen that here. Even the kids, you're trying to get them out, and they're minimally responsive, but they're breathing, they're protecting their airway, they're comfortable, so it kind of requires a reset from our standpoint. And I don't think any of you folks have trouble with it, but the floor nurses
Or day
will.
surgery.
Yeah, and day surgery,
Yeah.
because they're sending them home, and that's
Yeah.
where I think, we've talked about it as a group. Actually, I sent down an email about this because I think that, when we look at the discharge criteria, you want a patient that is responsive, okay? And you folks know that, kind of, you can gestalt that. Hey, Mel, ready? I'll be right there. But I think that for the day surgery nurses, it's hard to send them home when they're looking at that that's sedated. And so I think it's really going to be kind of a learning process for all of us. We may have to look at that. You know, if we're not having any untoward effects, I don't think it's a problem, but it does change the way we discharge patients. And the same thing with our anesthetists. Half the time, you know, 95